All right, good morning, everybody. Thank you once again to those who have come in person for today's Department of Medicine Grand Rounds. This morning, we have Dr. Timothy McBride. He's the Bernard Professor at the Brown School here at Washington University, just across the park. He's going to give us an update on Medicaid expansion in Missouri, and he's the perfect person to do so because he's the co-director for the Center for Health Economics and Policy. He's an expert in health policy and health economics. He advises local and state and national officials on health policy, and he's the chair of the Mo Medicaid Oversight Committee. So basically, I heard that if you have any issues approving medications, you take it with Dr. McBride. But without further ado, Dr. McBride.
Thank you. I'm not sure about that last one. I think I'd get in big trouble if that happened. So really pleased to be here. Thank you, Dr. Frazier, for the invitation and to see a lot of good old friends in here. So I'm really pleased to talk about Medicaid expansion in Missouri. And I've talked about this a lot in the last couple of years. And, you know, when I talk about it, people are somewhat surprised about where we're at with the expansion. So, and I want to give you, and I've been following this with a passion, and I call this talk Long and Winding Road. It's not just because I'm a Beatles fan, but because I am. In fact, I'm actually going to London this summer, and we're going to go to Liverpool, my brother and I. So that shows we really are Beatles fans. But when Medicaid expansion passed in 2020, I thought back to when was the first time I worked on a paper on Medicaid expansion, because it was kind of a monumental moment when it passed. And I realized that the first paper I'd written on this was in 2005. So it's been 15 years working on Medicaid expansion, which really is a long and winding road. And I didn't realize even then the road still had many turns in it. And I'll talk some about that today. First, some of the disclosures and thanks at the beginning. Almost all this work is supported by the Missouri Foundation for Health, which has funded our work looking at the expansion, both the implementation and now the work that's that we're looking at what's the impact of the expansion. So thanks to the Missouri Foundation for Health, although of course they're not responsible for what I'm going to say. And a couple of disclosures. I've been a member of the Rural Policy Research Institute Rural Health Panel for over 30 years. Now we're having our 30th anniversary this year, which we're pretty proud of, that they pay us to do work on rural health. And I'm chair of the Health Policy Advisory Council for the Centene Corporation. So you should know that when I talk. A few things I want to talk about today. Again, I want to give you a background on how this all got started, and then talk about where we are. But I want to spend the bulk of what I'm talking about on some early. I'm going to describe them as preliminary results about what the impact is of the expansion, and I'm going to focus in on the impact on hospitals because we have some data that we're analyzing on that, and then end with some talk about the future and some talk about what some of the future work is that we're going to be doing. So first, how this all got started, just to remind you, just sort of one slide, the expansion passed on August 4th, 2020. What was unusual about Missouri, we can't do anything simple in this state. We're the 39th state to pass expansion, but I like to point out that what's really unique about Missouri is we are the only state to have passed expansion by putting it into the Constitution. We were the 6th state to pass expansion with a ballot initiative. And because after the 38 states that went before that and went through the legislature, it became clear our legislature was not going to be for it. But other states went the ballot initiative route. We went the ballot initiative route, but there was fear that even that might lead to some blockage of expansion. So the advocates decided to put it in the Constitution, not just as a law. And that was somewhat prescient because you'll see that we went to the Supreme Court to get it implemented. Just a real quick background, and I'd be happy to answer more questions about this if you want. Just a reminder that what expansion does is it makes eligibility for people up to 138% of poverty level, which is about 32,000 now for a family of three, regardless of any eligibility status in the current, before Medicaid expansion, you had to fall into a certain categories like custodial parents or disabled and so on. But now you can go in regardless of your category up to 138% of poverty and without an asset test. And that's what's really important. The other thing that's extremely important is there's a big fiscal carrot to this in that the federal government pays for 90% of the costs. Whereas the current Medicaid recipients or the other Medicaid recipients, the state pays 35% of the costs and the federal government pays 65% of the costs. So that difference of between 90 and 65% is huge. It is a big carrot to the state. So that's just sort of a real quick background on the expansion. So the unique path that Missouri, this long and winding road I talked about, despite all that, the legislature, the first thing that Missouri had to do was pass what's called a state plan amendment and send it to CMS that in the federal government to say how we're going to implement Medicaid. We did that. Then the legislature refused to fund even the 10% of the dollars that they had to put in. That led our Governor Parson to pull back the state plan amendment, saying I'm not going to implement Medicaid expansion, which led to an immediate lawsuit that went to the Supreme Court on an expedited basis. Those of us who follow this knew that we were going to have a lawsuit one way or another. So that wasn't a big surprise, but probably a surprise was Supreme Court ruled unanimously in favor of the expansion. I think it was like, I heard one of the justices say in the hearing, I have a copy of the Constitution right here, it's right here. And I said, okay, they're done. So they began accepting applications in July 2021, and they began enrolling people in 2021. So the number that you may want to hear that like, where are we right now as of today? 322,781 people are in the expansion, which when I say that to people, there's some people that say, hey, have we started expansion yet? Yeah, 322,781 people in the expansion. And one of my jobs from for doing this for the MFH is to keep track of this weekly, and this is the weekly enrollment numbers in the expansion, and this shows you the sort of weekly walk that we've had in the expansion group. And you can see when we've hit some milestones, you can see we proceeded pretty slowly on this relative to other states. We hit 50,000 by the end of 2021. Most states got up to almost all the enrollment they expected by the end of the first year. In the first 2 months, we didn't do that. I can talk about why that happened later if you want. We had 100,000 by April. We hit 200,000 by August of 2023, and now we're at 322,000, as I told you. So after a slow start, we've exceeded the projections of the governor, who said we'd have 274,000 at the end of the first year. And my own center projected a number pretty close to that of about 250,000. So we're beyond those expectations. So one thing that I want to focus on mostly today is figuring out the impact of the expansion. I've perseverated on this, thought about it a lot with my colleagues. And, there have been 39 other states that have expanded Medicaid. So we got a lot of research on the impact of Medicaid expansion. And so is there anything new to say about it? But I'm beginning to believe that there is something really new to say about it. And what's new is that Missouri and Oklahoma are the first states to expand in the middle of a pandemic. And that's complicating this story quite a bit because it's turning out, I believe, very difficult to disentangle the expansion from the role of the pandemic. Let me sort of tell you that story. As you know better than most, the public health emergency started in February 2020, and it's about ready to end officially. But the important thing is that anybody who enrolled in Medicaid during the pandemic was not subject to recertification, so could not be removed from the rolls. And so our rolls in Medicaid have not dropped over time. And our rolls, I'll show you in a minute, in Medicaid have increased by 600,000 during the pandemic. And mostly that's in 4 different areas: the uninsured women's program, the pregnant women category, custodial parents, and a disabled group. And numbers that have recently been computed by our colleagues at the University of Missouri suggest that half of the population in the expansion category have come from these 4 groups. Half. And that's what makes this unique, I think. And so when the state started enrolling people in the adult expansion group, they moved people over from these groups. And a way to think about this, for example, as a pregnant woman might go into the Medicaid, and as you know, currently under law, you're eligible for a short period before and after the birth, and then you're rolled off of Medicaid. But in the pandemic, you're not rolled off of Medicaid, and you stay on the program. And that's happening all across the country. So Medicaid across the country grew to 91 million people. And in Missouri, this is what's happened to our Medicaid enrollment. We're at a record of 1.5 million people in Medicaid. And before the pandemic, we started in the 800s, and we've added 600,000 people to Medicaid enrollment. Of those 600,000, an increase of 622, you can see 622,000, about half those are from the adult expansion group. Notably, about 35% of those are kids. And so a little later on, when we start talking about the unwinding of the public health emergency, think about that 600,000 number, because some of these people are going to be the ones who are going to start losing Medicaid. I'm going to tell you later, just to give you a flash forward, that the head of Medicaid, Todd Richardson, stated out loud in a hearing that we're going to expect to lose 200,000 people in Medicaid by the end of the unwinding of the public health emergency. So we got 2 things going on here. We're adding people through the expansion, and we're going to lose them through the unwinding. But back on the expansion, here's a somewhat complicated graph, but on the left-hand side, what this shows, and these are numbers from our friends at the University of Missouri again, and in that green box, it shows you that looking at the December 2022 numbers, about 45% of the people that went into the adult expansion group were currently on the program already when they went into the adult expansion group. The other 55% had some recent exposure to Medicaid. They had been on Medicaid at some point in the previous 2 years or previously, but only about 25% or so had never been on Medicaid. And they were probably people like adult males, single adult males who had never been eligible for the program, but most of the people had had some exposure to Medicaid, and almost half of them were on the program already. And you can see on the right-hand side that I can do my laser pointing here. I think I can. The rest, these people in the reclassification category came from the uninsured women's program, the pregnant women category, the custodial parents category. Children, this surprised me when I saw this number. There's a lot of children that went from age 18 to 19. And I said, wow, 35,000. And I did the math on that. There are 600,000 children in Medicaid. So if you divide by 18, that's about right. So, and then a few disabled people rolled into the Medicaid population. So, what's notable about that is that a lot of the people, again, our Medicaid expansion is going to look different than other states' Medicaid expansion. So what this means is, how do we analyze this? And now I want to sort of segue to what we're doing on this. And we have this project to understand the impact of Medicaid expansion. And this is a real brief overview of what we're doing. And it's a long project over 3 years, and I probably expect it will look beyond that. And we're focusing in on access to care, especially in underserved rural and urban communities. It's a mixed quantitative and qualitative approach. We're doing key informant interviews. I'm not going to talk about that today, but that's really interesting and informative. What I want to talk to you about today is our quantitative analysis, which we have some preliminary results. And I'm going to focus in on the shift in the payer mix in the hospitals that we've seen as a result of some of the numbers that I just showed you. So, and how that varies by location and how that varies over time. So far, we haven't done a deeper dive on the demographics, including social determinants and diagnoses, but we're about ready to do that. And I'm going to invite any of my colleagues who are interested in doing Medicaid research to come join us. So the research on this is using what's called the HIDE data from the Missouri Hospital Association. Through our center, we have a data use agreement to use. We have all the hospital encounters in Missouri. We have it back to 2015. So we have a lot of pre-expansion data. And we have that data in hand already. And then we have a few of the months post-expansion until March 2022. Not very many months so far, but we're about ready to get a data dump to the end of December of 2022. But even with these months of 2022, we have most of the public health emergency data, as you'll see. And this, it's about 25 million encounters in emergency room and inpatient. Eventually, we plan to compare this to other states. We have administrative data as well, which I won't really talk about today unless you ask questions. I'm going to show you a few graphs to illustrate some of the high-level findings, and we can talk more about if there's anything else that jumps out at you. So here's sort of one sort of main way to look at this. And so what this shows, just to orient you, is the percentage of emergency department encounters by who's paying for it for 19 to 64-year-olds. And I've thrown out the other payers, Medicare, employer sponsored, because that's not changing very much. And I want to isolate onto the Medicaid and the uninsured so we can look at this. So there are other payers, obviously, but these are the ones that have been changing a lot. And here's the public health emergency when it goes into effect in about 2020. And here's when Medicaid expansion goes into effect. And what you'll see, the Medicaid line is the red line. It's going up, as you would expect. And the green line is the uninsured line, that's going down. And as you can see, the Medicaid is going up by 9%. And the uninsured line is going down by about 9% as well. So not surprising, but a fairly big effect to be seen already. But what's notable again about that is most of that was through the public health emergency. Those were those people that I talked about that were rolling onto the program and then were not being removed from Medicaid, you know, the pregnant women, the uninsured women, and so on. So that's emergency room encounters. And inpatient encounters doesn't show as a dramatic effect the way I see this, just to, you know, descriptively. There may be something going on after the expansion. We'll know more when, you know, in a month when we get the rest of the 2022 data. But, you know, and this looks pretty more stable, the Medicaid. But you see about a 6%, even with this, you see a 6% increase in Medicaid and a 5% drop in the uninsured since the public health emergency began. Again, looking at the 19 to 64-year-olds. I thought this might be interesting to do this, to look at I layered one other line on here, which is the Mo Health Net population as a percent of the Missouri population, which is the blue line here. So these are the percentage of people in the state that are in Medicaid or Mo Health Net. And you can see that it was sliding downward until the public health emergency hit. And then now it's sliding upwards and it parallels pretty much the Medicaid line. So that gives some suggestion of that's not a surprise what's going on with the Medicaid line across all the hospitals in Missouri. We've done some regional breakdowns of this so far, in part because this is what our grant is supposed to look at is rural urban. Why rural urban? There's a lot of concerns about rural hospitals closing. There's some issues about that, and as you probably know, there's political considerations with rural hospitals and so on. This somewhat surprised me when I saw this, but maybe I shouldn't have been surprised. The rural hospitals started with a higher proportion of Medicaid in the first place than urban. So the rural ones are the dash lines and the urbans, the solid lines. So Medicaid was higher in rural than urban was. And by the end though, urban is catching up to rural. So in metro areas, Medicaid's up about 8.5%, and uninsured down 6%. But in non-metro, Medicaid is up only 5% and the uninsured's down 7%. I haven't had a chance to completely disentangle this story yet, but a speculation I would have is that the reason why the Medicaid numbers are higher in rural areas is because the poverty rates are higher in rural areas. The coverage rates for Medicaid are higher in rural areas, so they started off at a higher level. The other thing that's going on is we're doing, I'll show you in a minute where, and I don't have it all in my presentation here, but I'm tracking this. There is a much faster rate of enrollment in metro areas than non-metro areas in Medicaid since the expansion started, especially St. Louis. By far the fastest enrollment in the expansion is in St. Louis City and County relative to the projections. In some of the outstate counties in the Northeast, Southeast, the Ozarks are lagging behind what was expected in terms of Medicaid expansion. So that probably might explain some of what's going on here. Just a speculation on my part. What we need to do is layer in the actual administrative data with this data to see if that's what's explaining this. And I think that will probably help us understand this. Here's what the inpatient numbers look like. They're much closer together. There's not a discernible difference, I don't think, between the rural and urban inpatient story, I don't think. Just recently this week, my data analyst put together these regional numbers. And these are BRFIS regions in the state, St. Louis, Kansas City, Northeast, Southwest, Northwest, Central, where Columbia is, and Southeast. And I ranked these by, put St. Louis on the top because we're in St. Louis, but I ranked them by the proportion of increase in the Medicaid population in the emergency room, not Medicaid population, but Medicaid encounters. And you can see there's considerable variation in how much growth there is in the Medicaid, and of course, proportionate sort of drops in the Medicaid or the uncompensated care uninsured encounters. Notably, I think the number of encounters is dropping overall everywhere. So that's all pretty interesting, I think. Still sort of disentangling what you're seeing preliminary early results. So any thoughts you have about what this all means? I have my own thoughts, but and then this is what the inpatient numbers look like, a little less dramatic. Again, a 5% increase in Medicaid payer mix and 5% drop in uncompensated care. Again, since the pandemic started. So that's a preliminary look at the encounter level data. Our colleagues at Missouri, University of Missouri have done some work on what the demographic composition of the Medicaid enrollees look like. Now, why would you be interested in this? I think there's probably a lot of reasons you'd be interested in this for disparities reasons. I'm an economist, and I think you might be interested in this for thinking about the costs of the underlying Medicaid population, the risk profile and all that. And it's probably of inherent interest overall. Some of this surprised me a little bit, but not completely. So if you look at the overall expansion population, it's 2/3 female, 1/3 male, which somewhat surprised me because that actually mimics the current Medicaid population. But when you narrow it to the ones that are new to Medicaid, not those that are rolling in from other programs like the uninsured women's program and pregnant women and so on, it's half and half male, female. And that may not be a surprise because, again, as I showed you earlier, about half of the people are in the Medicaid expansion came from the current Medicaid programs. Those are disproportionately female. Uninsured women's program, pregnant women, and so on. So that's where you're going to get 62 and 38. But it appears from these data that enrolling single males is still lagging behind probably what we would expect. 67% white and 33% non-white, mixing all the non-white categories together. That's more or less what the current Medicaid population looks like. It might surprise the average voter that it looks like that, but that's what Medicaid looks like in general in Missouri. And the age distribution did surprise me quite a bit. The adult or the expansion population is about half under 35 years old and about half over 35 years old. But the new ones that are new to Medicaid are disproportionately older, if you want to call 35 older. And that sort of means you put these numbers together, I think we're not enrolling a lot of young males, is what these numbers suggest to me. So that may be an interesting target for Medicaid expansion. Some of my colleague who pulled this together said, well, of course, that's what you'd expect because they're young invincibles. They don't think they should enroll in Medicaid. They don't think they need it. But on the other hand, this might be the first time they have access to preventive care and dental care and so on. They probably should enroll, but so this is probably an area we should focus in on some more. As I mentioned, the rural-urban issue remains a big one in Missouri, not just because rural hospitals are at risk, but because of the politics and other issues. I had predicted this in some of the numbers I had run before the expansion, and it's sort of playing out, that a higher proportion of the expansion population is from rural Missouri than their share in the overall population. So you can see that with the red numbers that I have on here, whereas about 1/3 of the population in Missouri is from rural areas, about 37% of the expansion population is from rural areas. So some people would be surprised by that. I think people in Jeff City would be surprised by that. I'm not surprised by that because of the rural health research I've done over the last 30 years, which shows that people in rural America in rural Missouri have higher poverty rates, lower incomes, less access to employer-sponsored insurance, and so on. And remember that urban areas include suburban areas, such as where I live in West County, where the uninsured rate is, 4 or 5%. So Medicaid rates are going to be pretty low there. So there's a pretty high need for Medicaid in rural areas, and we've seen this for the last 15 to 20 years. And it's playing out as expansion has played out. In fact, I had predicted in our preliminary estimates that we would see 40% of the expansion population coming from rural Missouri. So we're actually underperforming a little bit of what we had predicted, which suggests, again, that the outreach is not really happening as much. And a couple other things I want to show you, and then we'll turn to questions. We have a couple states that are expanding at the same time that present interesting comparisons, I think. Researchers love this sort of natural experiments, and I would throw this out to you as one of the more interesting ones. So Missouri and Oklahoma, two red states, expanded Medicaid at the same time. They're supposed to start literally on the same day, July 1st, 2021. And you can see a lot of numbers on here, but I'll point out after 6 months, Oklahoma took off. They had 237,000 people in their expansion. And we did not. After 6 months, we had 78,000 people in our expansion. Now, they projected they would have 200,000 in expansion. They now have 330,000. We have 322. So we've caught up to them. But we both exceeded our expectations of enrollment. But I point out to you over here that Oklahoma's 1/3 smaller population than we have, and they have a higher poverty rate. So, in fact, they've enrolled 8.3% of their population. We've enrolled 5% of their population. So there's something going on in Oklahoma that's not happening here that's of interest. And whatever Oklahoma's doing is something that we're not really doing. And we actually, there was an article in the Kaiser Health News early on. We started to write an article about this, and we called up people in Oklahoma and we said, what are you doing to make this happen? And then Kaiser wrote it, so we stopped writing it. It turned out they were doing an awful lot of outreach. They were going out to the counties in Oklahoma, and it was coming from the state. They had state workers banning out to parts of Oklahoma, signing people up. I kept on hearing about this person called Mr. Medicaid. Mr. Medicaid is out in this county. And I was like, who's this Mr. Medicaid? And then I found out, I think I found out who it was, but it was a state worker and he would literally say, we should have 500 people signed up in this county, and we only have 200. And he would dispatch workers to go to that county and sign them up. So that's surprising that that's the reason they're having the results that they have in Oklahoma. So, but the other thing I want to show you, and this is based on some data called the Census Household Pulse data. I'm not sure if you're aware of this, but this is another data set that we're tracking for this project in our center. Since the pandemic started, the Census Bureau at the federal government's been keeping track, or they've been launching a survey called this Pulse data that looks at a lot of questions around the pandemic, including employment, housing, and insurance coverage, disability, and so on. And it allows you to track and from the pandemic to about now, what's going on and across the US. There are some sampling issues that make me a little nervous about this, I'll be honest, but be that as may, the numbers seem to make some sense. And there are 3 states that expanded during the pandemic, Nebraska, Oklahoma, and Missouri. Nebraska expanded before Oklahoma and Missouri. And one of the things that you'll see here, and I put the numbers of change on the slide for you, so you didn't have to do the math. Basically, the Medicaid coverage rate went up about 3 or 4 percentage points in all those states, as you would expect. And the one thing, this is the only place we have so far that will allow us to see the impact on the uninsurance rate. And per this survey, there's been a 5 percentage point drop in the uninsurance rate in Missouri. The same in Oklahoma and a little bit smaller in Nebraska, but they started off lower. Just so you know, the official uninsurance rates in the US, there's a lag of about a year before we'll get those numbers, and it won't come out until later in 2023. And that'll be for 2022. So it'll probably be won't be until 2024 until we really know the impact of the expansions. But this is more immediate estimates. And you can see that in these 3 states, the impact is more dramatic than in the US, where the uninsurance rate dropped by 3 percentage points and the Medicaid coverage rate went up by 1 percentage point. And most of that's probably because of the effect of the public health emergency and emerging from the recession and so on. So all that is probably to be expected and something worth watching. So I want to make sure I leave time for questions. I want to sort of summarize where we're at. Just a few, sort of summary thoughts. Medicaid expansion was a hard fought victory for the advocates. I didn't even go into all the details about that, but we've enrolled about 300,000 people so far. It appears early on to be leading to fairly significant shifts in payer mix, and which is what you would expect. The expectations are that that'll probably have pretty significant positive impacts on those needing coverage. From prior research, that's what that shows. So that's where we're going to turn our attention next. There are challenges ahead. The unwinding, which I alluded to, when the public health emergency ends, states can resume their redeterminations, as it's called, and start looking at everybody on Medicaid and say, do you still belong on Medicaid? And there, as I mentioned, there are 91 million people on Medicaid nationwide. So what this is being called is the unwinding, and letters are going to start going out next month, April, very soon, in about 10 days, to people in Missouri. I'm on calls about every 2 weeks to talk about how this is going on, and we're breathing down the neck of the state to make sure they're going to do this right. Nationwide, the estimates are maybe up to 15 to 18 million people are going to lose their Medicaid coverage because of the pandemic, the unwinding. And as I said, Todd Richardson said that we are going to lose 200,000 people in Medicaid because of the unwinding. It'll happen over the course of a year. So what they're going to do in Missouri is start with the people who are the oldest on the rolls first, look at them and see if they're entitled to remain on the program. If there's evidence that they should remain on the program, if not, send them a letter and go through that process. And I'll work through the 1.5 million people over the course of a year. And first, I haven't been able to determine where they came up with that number of 200,000. So it's frankly, I think it's a real guess. But it's one of the largest estimates in the whole country. The Urban Institute came out with an estimate of 274,000 people that are going to lose Medicaid enrollment in our state. And they expect a 17% drop in Medicaid coverage and a 30% increase in the uninsured. So, in the end, we may go, 3 steps forward and 2 steps backwards in terms of Medicaid enrollment. I heard Todd Richardson say that we, starting off at 1.5 million, which includes the Medicaid expansion, we may end up at about 1.2 million in the end. And so the implications of that for providers and hospitals and safety net, you can sort of draw, it's probably relatively obvious, but we're going to have to watch this quite a bit. But on my to-do list is to try to figure out if this 200,000 number makes sense, and the foundation wants me to do that as well. Final thing I want to say is, from a researcher point of view, despite the fact of its impact on real people. The expansion is a great, what I'd call natural experiment. I want to make, in my role as co-director of the Center for Health Economics Policy. And, I think these kind of huge changes in our policy environment don't happen very often. And I think it creates huge opportunities for research. And not just to look at some of the really sort of surface level things we looked at today, but to look, deeper at things like what's happening in, I want to dig into certain diagnosis categories, what's happening to people with diabetes and heart disease and cancer and so on, and disabilities, chronic disorders. We have that on our files. We just haven't been able to dive into it yet because we're just getting the data. And, we have longitudinal records on people like this. We also have social determinants of health data on this. So we know, maybe not specifically for that person, but we know their location. So and then there's the effects of the unwinding. So my pitch to you is, if you're at all interested in this work, I probably need a clinician on the study to understand this. So send an email. We have great people in our center, including the phenomenal Karen Joint Maddox, but this will probably take a village to analyze this. But I frankly think if this at all interests you, I think there's a lot of great topics to dive into and look at. So hopefully that spared some questions. And I think Vicki, you said you were there's one already. So yeah, thank you.
Jim, thanks so much. I think we have time for a couple questions. We'll start. You anticipate there could be a fast or slow disenrollment. Typically, when in journal, but point out
Oh, thanks. That's for CME. The question was, do we anticipate that Missouri will be a fast or slow disenrolling redetermination state? And there was an article in the JAMA, I think you said, or New England Journal. I think we were nervous about that. And again, I've been on calls with the state because there's a whole slew of academics that have been looking at, advocates and so on, that have been trying to get the state to do the right thing. And I think they are going to do the right thing on this score. I think we'll be in the middle. There are some states that I think are going to do this very fast. They're going to do the unwinding and redetermine people very quickly. But I don't think our state's going to do that. I think, in part because we're watching them very closely, but also because they don't have the staff to do it. Because what they've told us, I didn't say it, but they're still getting 500 to 700 applications for Medicaid expansion every day. 500 to 700 applications for Medicaid expansion every day. So they're trying to staff up processing those applications, and now they have to go through 1.5 million people in Medicaid to determine whether they belong on the program. So what they're telling us is they will slowly deliberate and do it over a year. So I hope that makes sense. Yep.
Now Medicaid will be able to determine eligibility, or at the threshold qualifying things reverting back to pre-expansion poverty and things like that, income level changing again, or just a reassessment of
So the question is, for the clarification about the unwinding, is it purely determining whether, they're what's this entail? Is it looking at the pre-expansion eligibility levels, or is it looking at something else related to their record? It's kind of all the above. So when they do these redetermination states, or, frankly, I think some of this makes logical sense. When they look at a record, like people move out of the state, people die, like 18-year-olds age into 19. So they're no longer eligible for children's health insurance program. 600,000 people of the 1.5 million on Medicaid are children. So, and as I told you, that 200,000 of the increase in Medicaid is children. So, looking at those children matter. So a lot of what they're doing is just making sure they're still around. And then they check their eligibility relative to the eligibility standards. It should be pretty easy for the expansion because it's really simple. Is your income below 138% of poverty, period? And are you a citizen, period? That's it. That's the only two rules. And I actually asked them because, as you know, I used to be chair of the Mo Health Net Oversight Committee, and I'm pretty dogged about this. So I said, are you going to roll off the people on expansion because you just put them on? Do you really need to look at them because you just checked everything? And they said, no, we're going to look at them last. So I think the first group that we're going to be looking at is everybody else, custodial parents, the disabled, aged, and so on. Does that answer your question? Yeah.
Are they improved by there's evidence that investment in off, progression of the
Yeah, I don't think I can answer that question yet, but that's where we're going to look next. The only thing I will say is, and literally I just got it this week from my analyst, was those drops in number of visits, of emergency visits, was encouraging to me to see that, but I don't know. And again, this is why I'd love to have a clinician sort of look over my shoulder on this. How much of that is pandemic related? Were we having some of these visits? Because the whole pandemic's rolled into this. So my head is kind of spinning over how much do I disentangle the pandemic from the expansion? I really want to see the rest of 2022 to be able to answer your question, but you're right. That's why we bought data all the way back to 2015, so we can look at the pre-rates and actually do rates, and we can look at a rate. And I want to look at it by regions and actual hospitals, and we can do that. And we haven't done it yet to answer your question.
Then one of the biggest arguments for expanding Medicaid from the state's point of view, not provider's point of view, was the increase in federal contribution and potential financial impact to the state. Do you have any data on how the state has benefited financially?
Hopefully people heard that on the Zoom. The question was, one of the biggest arguments that the state would benefit financially, and we actually did that financial analysis, and we basically said, our center meeting, that the state would break even. And the main reason for that is that some of the populations that would normally go through Medicaid and get a 65% match, we're going to get a 90% match. And Dr. Frazier asked, is the early evidence on this? And I can tell you the early evidence is we were in fact right, and even more than we expected. And in part that's because part of it's because the Biden administration added an extra 5% bonus to so not only is it the 90%, but they actually are given 95% from the state. And so in fact, the state actually got close to $1 billion just by deciding to expand Medicaid. It was kind of funny, actually. The bill passed after we decided to expand Medicaid, but they said anybody who passed Medicaid after a certain date gets this additional bonus. So we got the bonus, and it was almost $1 billion. And then when it turned around to actually looking at the budget, they didn't need the money because they were actually saving the actual budget for Medicaid with the federal match. The state general revenue share that needed to go to the expansion was zero, which is exactly what we predicted. So what do they do with this money? They put it in a bank account to create a trust fund. So there's a trust fund sitting out there with this $1 billion sitting in it. And the chair of the House Budget Committee said, I don't want to touch that because in the future we might need it because I don't believe that this world will live like this forever and we're going to need it eventually. He may be right, whatever, he may be right, but that money's sitting out there. So
States that have been more proactive about expanding, Medicaid roles in the past, Oregon back in the looked at perhaps narrowing benefits a little bit to cover more people. Are there other states that are doing either something similar now or other novel approaches to expand Medicaid? Is that something that has ever been discussed again?
So you're talking, the question was, are there states that did novel approaches to expanding Medicaid? And I assume you're talking about like what Indiana did and Oregon did, and where it's not just sort of a straight expansion, where you just like what we did, just raise the eligibility level and don't do anything else. Iowa did this, Arkansas did it, Indiana, a few other states. Those states put those plans into place. There haven't been a lot of new ones that have done it. And frankly, there haven't been too many new ones that have been added since Missouri. But amazingly, North Carolina's about ready to pass Medicaid expansion. South Dakota put it on the ballot and they're about ready to pass Medicaid expansion. But to answer you directly, your question, I don't think anybody's going a novel approach, although there are, which means, doing some sort of, health plan provision or doing some value-based purchasing or some sort of twist like that. Although I will tell you, even in our state, to their credit, I think they're looking at, are there different things we could do to bring our Medicaid program up to 21st century? Because I don't think we're there yet. So, and we're working with them a lot to do that, actually. So.
I think we got to stop now, but why don't you come down if you have additional questions for Dr. McBride? Thank you very much.
Oh, thank you. So. Hopefully that works. Oh, sure. Nice to see you.
Yeah, nice.